a few here at CIRA at 135 College. And today we're really fortunate to be joined by Dr. Lucy Chimoyi from South Africa and Dr. Iryna Zaviriukha from Ukraine. And I'll give a little bit more introduction in a little bit. I'd just like to kind of share a little bit about the International Visiting Fellow program before we get started. And the International Visiting Fellow program and about CIRA in general. So CIRA is a P30 center supported by the National Institutes of Mental Health to support social behavioral interventions and AIDS research at Yale. And you can follow us at cira.yale.edu, including we'll be kind of covering the events today and other activities that are going on at CIRA. So for today's panel, we'll start with an introduction and then we'll hear presentations from both Lucy and Iryna, and there'll be a chance for questions and answers. If you're online, you can ask your questions at any time and we'll be monitoring the chat. And Dini Persona will be helping me keep an eye on that and bring up your questions at the end. And then there'll be a chance for closing. And those that are here in person, if you're able to stick around afterwards, we're going to have a brief lunch and a chance to spend some time with Lucy and Iryna. Please also, if you're attending, look out for an email after the session. We're always trying to get your feedback on the type of content that we're providing and the way the webinar has been set up today. So if you have any input, please fill out the evaluation survey. And especially if you have topics that you think are important, that you'd like to hear covered through our CIRA International Visiting Fellows program or other webinars that we have, please do so. So the International Visiting Fellows program is designed to support CIRA investigators, so affiliates that we have here at Yale, but also at other institutions that are collaborating with us who are engaged in international research, especially in the international setting. To bring established or prospective partners here to Yale for a chance to kind of spend time on campus and meet new collaborators or work with existing collaborators on new projects. And we also like to have a chance to kind of hear about the research that you're doing and the research that you have planned and just generally network with the CIRA community. And we prioritize visiting fellows for programs from countries that have regions of the highest burdens of HIV/AIDS. And by doing so, we can support research that can have a substantial impact on the global HIV epidemic. And we're particularly interested in the use of implementation science, improving health equity, addressing structural racism and colonialism in research, involving community engaged research methods, integrating HIV services and digital health. So these are some of the themes of our newly refunded P30 application through the National Institutes of Mental Health. And this International Visiting Fellows program was first established in 2016, and we've hosted 4 scholars in 2016, 4 in 2017, 2 in 2018, and 3 in 2019. And we're really excited this year to be rejuvenating the program after the pandemic and welcoming Lucy and Iryna. So today's seminar has been organized by Dr. Sheila Chimoyi and myself and Dr. Julia Rosanova. Sheila and Julia are hosts. And we're very happy to welcome Lucy Chimoyi, who is from the Aurum Institute in South Africa, and Iryna Zaviriukha. So I'll just start with a brief introduction of Lucy, and then I'll give an introduction of Iryna before she talks. So Lucy is an epidemiologist who works as a scientist at the Aurum Institute in Johannesburg, South Africa. She has over 10 years of public health research experience, and she conducts both mixed methods research and also quantitative research on HIV/TB in correctional facilities, mining and general communities, and also public healthcare settings in South Africa and also in other regions of Sub-Saharan Africa. She's authored or co-authored over 25 publications in peer-reviewed journals, and she's an honorary lecturer at the School of Public Health at the University of Witwatersrand in Johannesburg. She's currently involved in the implementation and oversight of a multi-site, multi-country study that's investigating tuberculosis preventive treatment, initiation, delivery, and uptake among persons living with HIV in clinical settings. And so I'll turn it now over to Lucy to tell us a little bit about her research.
Thank you for that introduction. And I'm just going to go straight into the topic of the day, which is generating evidence-based solutions for optimal delivery of TPT among people living with HIV, and especially with the 10 limited settings in Sub-Saharan Africa. So I thought maybe we should just start with the most recent figure that is showing the global HIV index, and we can see that the HIV negative patients or people are having a higher increased rate of TB infection, and the HIV people that are living with HIV, the number of HIV-related deaths are actually decreasing. And the orange line is to show the TB-related deaths among people living with HIV. And for the last 20 something years, the rates have been increasing. So this slide sort of has has some good insights, and it's also showing us exactly where we should be focusing. And maybe that's the premise of this presentation. So when you're talking about TB preventive treatments in high-practice settings, we know that TPT has been considered as one of the best interventions to prevent progression of TB disease. Of prevention of TB infection into TB. However, we know that globally the implementation of TPT has largely remained suboptimal, particularly in areas that are low and middle income settings. And some of the barriers have been included or articulated well, such as insufficient awareness of TPT importance by healthcare workers. This also citing of limited engagement of TB programs in preventive strategies. Then there's a limited capacity to diagnose TBI, and then of course there's insufficient availability of the TPT regimens, and also an availability of knowing what duration TPT needs to be prescribed. So I'm going to talk about evidence for some of the hypothesis studies that the Aurum Institute has been involved in with regards to TPT in the last couple of years. So I'm going to start off with a study that was conducted in 2016, and it was not really a study on TB preventive treatment, but this study was in a setting that is actually quite relevant in this day and age. And the study was called Treatment as Prevention. It was a multi-site mixed methods implementation research study with the main aim of trying to understand whether it was feasible to introduce universal test and treat in the correctional services. At that point in time, countries had just started implementing HT. So that was the main aim, but the focus on for this presentation is the one of the exploratory aims that came up when we were looking at the data, and part of it was we collected information from clinic stationary amongst inmates that were incarcerated for at least 2 years, and then we also collected information on TPT delivery. So we went ahead to describe the TPT delivery situation in 4 correctional facilities, 3 in South Africa and 1 in Zambia.
Hi, Lucy, I'm sorry to interrupt. We're just having trouble hearing you online. I was just wondering if there's any way the mic could come closer. Sorry about that.
The plan is that,
Yeah.
it's a little awkward here, but let's see.
Yeah. Anne, can you hear me?
That's much better. Thank you so much. Thank you.
All right. Okay, thank you, Anne. All right. So the next trial that was conducted by Aurum was the WIP3 TB trial. The WIP3 TB trial was a parallel to open label trial that was comparing three different regimens of TPT treatment. The first one was the patients were enrolled and then they were randomized to just receiving 3HP once. And the second arm was randomized to receive 3HP, but for 2 years. And then the last one was randomized to receive 6H for 6 months. The main aim was to compare the treatment completion rates of the 3 different arms, and also and another aim was to understand the effectiveness, or to assess the effectiveness of the 3-month 3HP given annually for 2 years versus the 1. It was conducted amongst people living with HIV, and it, in those 3 countries, South Africa, Ethiopia, and Mozambique. And the eligibility criteria was anyone who was 2 years or older and did not have active TB. And then moving on, there was the Impact for TB program that has been spearheaded by the Aurum Institute. And the main reason for this program was to increase market shaping for 3HP. And this program was conducted in 12 countries. You can see in the map below. And there was several tools that were developed and job aids to assist with just talking about the 3HP as it was being introduced. And most of these tools were tailored to the different country contexts. So the project was started in 2017, and it's still continuing. And the main aim was to generate evidence on 3HP across different populations. We can see that there was generating 3HP on people that are ART naive, also similarly to children, and also we're looking at child contacts. And lastly, there was a study that was investigating an opt-out strategy to increase TPT uptake. So all these studies are almost complete. Some of them are complete, and yeah, the investigators that are associated with these studies are busy looking at the information. Yeah. Again, when you look at the impact for TB, what was mainly important was to try and reduce the price of patient courses for 3HP, and also to incentivize the development of optimal formulations and increase the global capacity. So the impact for TB study kind of gave birth to the Opt4TPT study. So the Opt4TPT study has leveraged a lot on some of the infrastructure that was set up by the Impact for TB. And out of the 12 countries that the Impact for TB was being implemented, we implemented the Opt study for in 3 countries: Ethiopia, Zimbabwe, and South Africa. And our study implementation partners in Zimbabwe were CHAI, Clinton Health Access Initiative, and the implementing partners in Ethiopia were CB+. The study period was between July 2021 and December 2023. And the Opt4TPT study is basically a programmatic assessment of the delivery of TB preventive treatment, with the main aim of generating some critical information that is geared towards improving TB preventive treatment uptake, implementation, and patient outcomes. In terms of the approach, we had 2 big umbrellas of in terms of how we packaged our main objectives. We had both patient level factors and we had clinic level factors, and each and every objective, was had its own data source and approach. But the main outcome of the whole study is to make recommendations to various ministries and departments of health on how to optimize TPT delivery from a health system and a patient perspective. So at the next section, I'm just going to be talking about some of the findings that we got from, we're still getting from the Opt4TPT study. Some of these have, so we've only managed to disseminate in 1 country. So some of these findings are they're mostly preliminary findings, but I'm going to try and explain exactly what some of them mean and how they fit in the context. So you do recall I had mentioned that the Aurum Institute conducted the WIP3 TB trial, and the WIP3B trial showed compared the treatment completion rates between the 3HP group and the 6H. So this is in a trial setting, and we got 90% participants or patients completed the 3HP versus 50% of the patients completing 6H. So when we look at our study, the Opt-for-TPT, and most of it, we had two sources of data in terms of treatment completion. First of all, we abstracted the information from clinic records, and we can see in this bottom graph that treatment completion for the 3HP patients was 88.3%, and treatment completion for the 6H or 12H patients was 84%. But then when you look at the TPT completion using a semi-objective marker, which are the digital adherence tools, and this is how the box looks like. It's called an EveryMed box. We saw that the same patients, rather not the same, but a subset of the patients that we followed up in the study, only about 59.2% reported treatment completion when we assessed using the EveryMed box, compared to 29% of those that were taking a 6H or 12H. So this is just showing you some of the gaps that we are also identifying as we look through the data in the study. In terms of the TPT cascade of care, this graph comes from the study that was conducted in the correctional facilities in Zambia and South Africa, and we can see that the cascade drops as we look at the proportion that were eligible for TPT evaluation. The proportion drops further for those who are screened for TB, and even further for those that were initiated on TPT. And this is the situation that is just common in most of the correctional facilities because of the untimely or transfers and releases that affect TPT delivery, and some of the information that is supposed to be completed is not adequately completed in the records. Part of Opt-for-TPT study, we had a PhD intern from Yale, Ann Johnson, working on TPT monitoring using the digital adherence tool, the EveryMed box, and we saw that we had defined completing TPT according to the WHO definition, which is more than 11 doses of 3HP per patient, and we see that about 50% of the patients or the participants that were enrolled in the study actually reported completing all the 11 doses that was stipulated. So again, we're seeing a gap in treatment completion of TPT amongst our PLHIVs. From the Opt-for-TPT study, we also tried to understand if there's any there's any traction in the differentiated service delivery models. And what this slide is just showing is that although most of our patients were people that were stable on ART, majority still came back to their clinic for their mainstream care. Very few participants were picking up their medications from the community or from the adherence group. But these results are basically purely for the Zimbabwean site because we've already disseminated in Zimbabwe. So the other results we're still working through them. So remember I had mentioned that this was a qualitative, a mixed methods study, and we also had some qualitative research that was we conducted through in-depth interviews and observations. So the qualitative interviews are revealing some kind of other questions that we need to be thinking about. So the first one is whether the time allocated for TPT counseling is sufficient. We found that in terms of the observations that we made, most patients had about 3 to 5 minutes of TPT messaging allocated to them. So is that time sufficient? At what point in the patient's clinic journey should TPT education be provided? The next time, the other points that, other points that were coming through from the in-depth interviews were whether what would be the most appropriate method for monitoring TPT uptake in patients, because most of the time we had our study was conducted during COVID, and there was a lot of multi-month dispensing of TPT, and there was not really much of monitoring other than when the patient had already completed their treatment. In Zimbabwe, we came to understand that there was a lot of there was not much of facility-based training. There was also just selective training of healthcare workers, and the information just needed to cascade down to other healthcare workers. During the dissemination workshop, there was a suggestion that maybe the facility-based training is a better model to ensure that healthcare workers are more up to date with the TPT guidelines, and they are able to handle and manage their patients effectively. We also looking at what would be the best ways we can, how best we can approach, or how best we can introduce person-centered approaches in improving TPT deliveries. That's some of the information that came out through the in-depth interviews. And lastly, were there messages, what can be done to reinforce motivation messages to promote adherence, address psychosocial issues, and what platforms should be adopted for this. So the last part of the TPT study was the value stream mapping, and this was just to understand what the patient's journeys from the time they came to a facility when they went to pick up their medication from a DSD site. And we can see that we had 3 different types of patients. On average, patients took about between 8 and 24 minutes in an ART TPT room, but out of those 8 to 24 minutes, there were just about 3 to 10 minutes on TPT time that was allocated for that. In terms of and then between the TPT room and the pharmacy, there was some time where they were queuing, and they could queue for between 2 to 15 minutes, depending on how busy the clinic was at that point in time. And this is the same pathway that was seen with different times for the DSD patients. So even as we are concluding, we know that the global TB report reported that in terms of TPT, the targets have been reached for people living with HIV. But even as we are doing these studies, we still think that there's some gaps that need to be addressed. We know that TPT is very effective and feasible in high prevalence settings, but for there to be successful scale up of TPT, there needs to be attention that is given to all steps in the cascade. And we know that the greatest dropout typically occurs when someone starts therapy. But so we think we need to get programs to adopt a patient-centered approach to ensure that there's optimum delivery of TPT. With the introduction of shorter course regimens is a great promise to improve TPT completion. I mean, we've seen from the graphs that have been presented, but then there's also just needs to be more operational research that can help localize the use of preventive treatment in high burden settings in Sub-Saharan Africa. So I want to thank you, and I want to acknowledge our partners and funders.
Thank you, Lucy. Maybe you want to stay close to the microphone and have a few questions from within the room, and then we may have some questions also online. So nothing yet online. So I had a question for you just to start. You kind of alluded to it at the end, and we have these shorter regimens, only 12 doses over 3 months. But is that still too long for people living with HIV? To have to take therapy for TB preventive therapy? Do you feel like the 1 HP, the 1 month regimen, is that something that we're likely to see in South Africa in the near future? And would that, based on what you find out from your study, would that be better to have a daily regimen than a weekly regimen? What were some of the things that you're hearing back from the staff and the patients about the duration of treatment for TB preventive therapy?
All right, so I think the responses are diverse. There's a group of patients that actually prefer a daily treatment because the 3HP is just once a week for 3 months, so people would have a tendency to forget. But there's a group of patients that actually prefer the shorter regimen because they know they're just going to take it for 3 months, and it's only once a week, and they think that they can tolerate it better with the ART. So I think at this point in time, it's a matter of choice, and different strokes for different people. Some people would prefer the longer treatment. Some people would prefer the shorter treatment. But in South Africa at the moment, we're still giving the 12H for people that are living with HIV, and the 6 months isoniazid for people that are not living with HIV, the household contacts. And we've just introduced 3HP, and the scale up has been a bit slow. Yeah. So, but what we have been getting feedback from the clinics facilities that they actually prefer 3HP because it's shorter, and people tend to complete it much. I mean, they tend to stick to the regimen until the end, as opposed to the longer treatment.
Do you see any differences in the completion rates among the people that are getting community-based antiretroviral therapy and the ones that are coming to the clinic? Is there any difference in the completion rates between those two groups?
In terms of the TPT?
For TPT, yeah.
I'm not sure if I have any data to support that. Yeah, so maybe something that I need to look into.
Be interesting.
Yeah.
Super, thank you, super. If you can comment about an optimal TPT or some of the other impact studies about the concurrent ART outcomes, biological suppression rates in people who may or may not be.
That's a good question. I was asking more about the TB preventive therapy, but
Yeah.
what happens to their ART adherence, their ART?
Because TPT is only for people with HIV at this point. And
Yeah.
so they're taking, I think you and I talked about this separately. There's a lot of pill burden, even if it's not that we, because Southern hasn't adopted the dose combination for the TPT.
Yeah.
So it's like 10 pills.
Yeah.
Once a week.
Yeah.
In addition to the ART. So I'm not sure if you have the information about the environment.
No, unfortunately, one of the biggest limitations for this study is that we did not collect any blood to do viral suppression, and the information that is from the clinics is not. It's not. For lack of a better word, I can just say it's scanty, because these are people who are in care. They probably come for their annual visits, and so we managed to just abstract about we enrolled about 2,000 patients, but we've managed to abstract viral load counts for about a half of those. So, but I'm not exactly sure whether the majority of them were suppressed, but I'm not exactly sure of the number as yet. Yes.
So I think that's not uncommon what we see in sites. People will take their ART.
Yeah.
Relatively faithfully, but then
Yes.
there's a selective adherence bias, or they're preferring the ART over their TPT.
Yeah, that came a lot from the qualitative interviews. Some of most of them were very committed to taking the ARTs. Even for those that refused to take TPT or discontinued, when we asked some of the questions whether they are continue to take the ART, they all said yes, we still taking our ARTs. Yeah.
There are a couple of questions on Zoom from Alex Kitiawezi. So completion rates were higher in the intervention and programmatic setting. However, when a subset of patients were digitally monitored, the completion rates were lower. What could have caused this?
So in the trial, the completion rates were high. That's granted, and we all know how a trial is conducted. It's very strict, pedantic way of doing stuff. So that I'm very confident in that result. So when it comes to a programmatic setting, when we were doing our monitoring visits across the three countries, we noticed that remember the study was implemented during COVID. So there was a lot of multi-month dispensing. So in terms of the drug would be dispensed, especially the 3-HP would be dispensed. And then at the end of the 3 months, they would call the patient and ask whether they completed the treatment. And the healthcare worker would literally just backdate the dates. Or sometimes when they give the drug, they will just write the dates for those 3 months. So that's what happens. That's what happened, and that's why you can see all those high treatment completion rates. And the same observation was made when the Impact for TB program was going on. But with the every med box, the box itself, there could be many reasons why the completion rate was lower. But some of the reasons would be, in terms of connectivity of the boxes, we had, maybe I must just step back and say that the box has reminders. So during the study, we removed all the reminders, and the box continues counting days, even though there are no intakes that have been recorded. So sometimes you might, if you don't proactively go and the participation on the back end, it will continue counting the days. So even that in itself, has a kind of posed a lot of problems for us, because there's a lot of data cleaning that we had to do. But nevertheless, we believe that we've cleaned the data as much as possible, and the treatment completion rate is comparable with what Anne Johnson, the PhD student, also got. So we believe that is the observation that we're seeing from the study. Thank you.
Thank you, Lucy. I think we'll now move on to the second presentation, but let's give a round of applause for Lucy. And we'll share the other questions that we got online with you by email, so you can have those. So our second presentation, I'd like to introduce Dr. Iryna Zaviriukha from the European Institute of Public Health Policy in Ukraine, and she's being hosted by Julia Rozanova. So Iryna graduated in 2001 from Vinnytsia National Medical University and received the Doctor of Medical Sciences degree. She has medical practice as an anesthesiologist and reanimatologist in the Department of Thoracic Surgery, the Department of Reproductive Health, and the Department of Intensive Treatment of Infections. Between 2012 and 2015, she participated in clinical research as a clinical researcher in neurology, psychiatry, and oncology. And since 2015, Iryna has been a researcher at the Ukrainian Institute of Public Health, where she's been engaged in conducting research in the field of public health on treatment of HIV infection among people who inject drugs, review and improvement of the mechanisms for providing HIV services for target improvement population groups. And then since 2017, she's been working with colleagues at Yale, including Julia and Sheila, on creation of the current program of HIV and aging research in Ukraine. So we're so happy to hear from Iryna. She talks about resilience of peer navigation among HIV-positive older people in the multi-crisis during the war in Ukraine.
So my presentation named Resilience of Peer Navigation Among HIV-Positive Older People in the Crisis During the War in Ukraine. Our project named, our general project named PROST project. Why PROST? We have 4 letters, PROST. It means peer-run optimal strategy of treatment. As I remember, Julia says about this name. Why people living with HIV 50 plus? When we began our collaboration in 2018 with researchers from Yale University led by Julia Rozanova, based on collected quantitative and qualitative data in Ukraine, we found that the number of new reported cases of HIV infection among people over 50 years of age in Ukraine has been growing over the past 6 years. Data showed that people age 50 plus years old with HIV constituted the only group where HIV incidence increased significantly from 8% to 12% between 2014 and 2016. We classified this target audience, older people with HIV, as a new risk group for HIV infection in Ukraine among adults aged 50 years and older. Since this group is very closed, why is the peer navigation? Since this group is very close, at best they will agree to make contact with an infectious disease doctor. The age of the medical service providers matters to them. They rarely trust social workers, especially young ones. We decided to organize assistance supporting from peer navigators as part of the PROST study. PROST study named adapting peer navigation for out-of-care older persons with HIV in Ukraine. The idea of the project was born before the pandemic in 2020. We have been implementing this project from the end of 2021 in Ukraine until today. And we can say that this project has survived the pandemic and the war in Ukraine. You can see all our team, the best team from Yale University, from clinical hospital in Ukraine, from site clinical, and from European Institute of Public Health Policy. And one person, Natalia Radic, is our supervisor, is a practical psychologist. For older people with HIV, we developed a peer navigation program consisting of a team of 6 peer navigators, 4 women and 2 men, running June to December 2023 in Kyiv City. Peer navigator eligibility criteria included being older people with HIV with virologic suppression for at least 12 months, and crucially, wishing to help other older people with HIV. Clients' eligibility criteria were out of care, older people with HIV, including both recently diagnosed and long-term loss to follow-up, no receiving treatment for 30 days or more, and living in Kyiv or Kyiv region in Ukraine. PROST enrollment strategy, it was difficult and very long time consuming process. The clinical site team, social worker, infectious disease doctor, and nurse included experienced and motivated HIV clinic personnel to serve as a research site staff conducting preselection, screening, enrollment, and assessment at baseline and follow-up visit. HIV clinic personnel have legal access to HIV patient records allowing for a fast preselection of the eligible candidates for participation in the study. As all of them are employees of this clinic, which is very important for the formation of trusting relationships with potential participants. The National Electronic Medical Information System had a fundamental application is our assessment, as it provides to be an effective tool in patients' identification for screening and enrollment into our study. We used adequate participation compensation, which in the light of economic context created by the COVID-19 and the war provided to be an effective tool to maintain optimal enrollment and retention rate. What about recruitment of peer navigation? It was a short period, but very energy consuming process. Recruitment of peer navigators was carried out by the study coordinator using the help of infectious disease doctors at the clinic who would recommend their patients as potential peer navigators according to the inclusion criteria. Those 5 peer navigators were recruited. An advertisement was also placed in a close group of HIV-positive people on Facebook. This made it possible to recruit 1 peer navigator. Recruiting and enrolling peer navigators weren't complicated and required a lot of energy and time. Our goal was to recruit 10 to 12 people to work with 60 participants. I had a list of about 50 people from medical workers. About 5 people refused immediately, 3 people agreed but refused just before the training, and 1 potential candidate refused during the training, and 1 already trained peer consultant did not work with us for personal reason. He had to take care of his mother. We have 6 navigators who actively work with us and who live in Kyiv, ready to provide support in any form, in person, online, by phone, in messengers, etc. This is our team of peer navigators. On the right side, our supervisor, Natalia, she is a practical psychologist. I said about this. Peer navigators were trained, including motivational interviewing techniques by Natalia, by supervising the practicing psychologist. And HIV physician was appointed to be available for consultation on medical questions by the peer navigators. This is the best team of peer navigators. We learned that the appreciate capacity for each peer navigator is 5 to 7 older people with HIV for 3 months. Over the 7 months, the supervisor conducted 10 group consultations and approximately 30 individual consultations for each peer navigators. We learned that one of the major obstacles for peer navigators was how to draw appropriate boundaries between themselves and their clients. Consultant lived with patients' problems. All consultation took place in a hybrid version, offline or online, adapting to the wishes of the peer navigators. Peer navigators preferred in-person group discussion of cases and problem solving rather than online meeting. There was less demand for consultation with the HIV clinical than expected. With 3 group sessions and 5 on demand individual consultation over 7 months. Through peer navigators were initially hesitant to share their own experience as older people with HIV. Through facilitated guides from the peer navigator supervisor, peer navigators practice involved to disclose their own experience with HIV and RT to help their clients. A commune of people was formed who are able to cooperate and be friends. So supervision process, it was in offline supervision in our office. So as you see, very confident, relaxed atmosphere. It's online supervision in the process, just visualization, just for visualization for you. As a supervisor, so it's a cloud from supervisor notes. The supervisor kept a consultant journal where she noted all meetings, online or offline, group or individual, and also took notes during the supervision. So I made a cloud visualization from the supervision's comments. As you can see the most popular word during the supervision from our supervisors. Supervision activities are aimed at improving the professional training on peer navigators, optimal distribution of workload, timely identification of signs of emotional burnout syndrome, and assistance in overcoming it, and adopting the accumulated experience from colleagues working with people, for example, psychologists, psychotherapists. It is important to organize supervision in such a way that it is perceived by consultants as a tool of help and support rather than control and punishment. Here is a visualization of the other side of supervision, comments from the Journal of Peer Navigators about their works in clients. The navigators understands the client and his request more deeply, quickly gets to the root of the problem or difficulty the client is in. For example, some clients did not know how to obtain RT treatment, and navigators helped them organize the delivery of medicine by post office. We have the word post, I think, maybe it's in the house, this cloud. Just quickly project progress. We enrolled 94 participants during 6 months. But initially we have a list from medical record in hospital from 327 potential candidates to be the participants. 63 participants randomized in the first intervention, and 31 participants in the standard of care group. From 94 participants, we have 37 new participants, it means registered for the first time at the AIDS center, and 57 old participants previously registered with the AIDS center and lost to follow-up. Follow-up visit is conducted. We completed 3 months follow-up visits. Now conducted is conducted 6 months follow-up visit. And unfortunately, we have 6 participants died. The cause of death, AIDS, pneumocystic pneumonia, oncology, acute cardiopulmonary failure, and cirrhosis, and unknown reason. Okay. Conclusion. So conclusion, supervision finding. Peer navigators working with older people with HIV require both social and professional support to cope with their personal challenges. Flexible supervision following older people with HIV needs was vital for peer navigators' survival and maintain their mental health under the multi-crisis conditions during the war in Ukraine. In the PROS project, peer navigators had the opportunity to receive not only supervision support, but also personal therapy sessions. This approach showed very good results. In personal therapy, consultants had the opportunity to work on their own emotional problems, which in turn allowed them to become more stable in working with clients and choose the right path to help the person was assigned to them. In the supervision of PROS projects, the following goals were set and achieved for the supervisor. Improvement of consultants' skills, improving communication skills with clients, getting rid of value judgments, optimal use of opportunities, improving the quality of services, achievement with theory and practical knowledge, finding your own consulting style. Thank you for your attention. Thank you for inviting me. Thank you for opportunity to be here. So many questions.
Right, so we'll open it up to questions, and we'll see if we have some online, but Sheila, would you like to start?
Yes, thank you very much. I mean, I think I know some of the answer to this, but maybe from my work in South Africa, where we try to engage people using community health workers, which is even very similar to peers. We found that gender concordance between the peer or community health worker and the client is very important in quality of engagement. I don't know if you can comment about if that's come out from some of the data. I think we've discussed this, but I'm just curious for this group.
Okay. Julia helps me.
Разно. То есть они хотели, чтобы их навигатор был того же самого пола.
Yes, I said about this. Yes, because they feel, I mean, all the people with HIV feel not good, feel not convenient with young medical provider, especially a lot of social workers have a young age. So it was not comfortable, and so when we provided qualitative in-depth interviews and focus group interview before the post-project started, we finding that this problem, I mean age of medical providers. So we decided to organize this intervention process. So
Ира, пол имел значение?
yes, gender, yes, it's имело значение, как это сказать?
Mattered.
Yes, it matters, but not much that age.
Age does not.
Yes.
Thank you.
No comments on Zoom.
I have a question. So, based on your learnings, what is the best way to recruit people to be peer navigators? What criteria would you use to recruit people? And if you could just say a little bit about what the commitment is. Is this something you're doing part-time or full-time? Are they getting paid? Some of those details. Thank you.
Okay, about recruiting, yes?
Yes.
И если у них была какая-то зарплата, лучше, чтобы мы потом могли делать, например, полную занятость им давать, или же это будет, ну, как бы, скажем так, работа, как подработка, вот как лучше.
Yes. As I said previously, it was recruitment of peer navigators was energy, very much energy consuming and time consuming. Maybe I was a main recruiter. Yes, but I used my connections, my experience, experience from my colleague from hospital, from AIDS hospital. So I used this resource. This resource was the first step. The second step was it was my role. So I contacted with peer navigators and tried to recruit to our project. I have a lot of refused of not a lot, but many refused from participate in this study, to be a peer navigators, but we can recruit 6 navigators, as I said. And about compensation to for the work of our peer navigation, we choose at the first we advised with consults with administrative personnel in AIDS clinic about how much. So they advised it should be not more the pension,
Salary,
not more the pension in Ukraine, especially, but not more, the middle without pension in Ukraine and minimum, минимальный прожиточный минимум. Прожиточный уровень.
Not the
Minimum level, minimal.
poverty line, so it should be between the poverty line and the lowest pension. It should be a proportion of that amount. So it's not to be more than, you know,
They're modest.
it's not
Yes.
excessive. Yeah.
So compensation was not more than pension in our country. So it was low. It was we named this work as voluntary in our project. Peer navigators knows about this, so they knows about they are peer navigators, they are consultants, and they are volunteers.
Well, thank you. I think we're at the end of our time. So I'd just like to have a little round of applause for Iryna and also for the meeting. I want to thank very much CIRA for supporting the International Visiting Fellows Program, and especially to Denny and Pete for helping organize this. Thanks for everybody who joined today in person and online. Please fill out the evaluation that'll be coming to you by email. For those who are here, stick around. We're gonna have a short lunch and we can talk more with Lucy and Iryna. And I'd also just to highlight the CIRA Early Career Scientists is putting together a symposium next Monday afternoon from 3 to 4 p.m. You can find details online in terms of registering or Zoom links, where we're going to be talking about NIH peer review, Sheila, Jeff Wickersham, we have Jamie Meyer and also Lauren Nelson. So it'll be a great session if you want to learn more about NIH review. So once again, thank you very much and have a good rest of your day.